Chetana, Department of Homeopathy. He will present lung cancers stage 3B and 4. Homeopathic intervention, a case series study. So, on behalf of IFPH, I welcome Dr. Vinu Krishnan. Please come.
Good morning. Let me record my sincere appreciation and gratitude to a forum where the homeopathic diaspora has been invited, creating a virtual reality over the past years. Maybe many of our organizations get misconstrued over this formation, but now the result speaks for it. Pan-Indian and across the nation, people are gathering on behalf of this forum. So I congratulate the organizers behind. So my topic of today's discussion is a case series study on advanced cancers, just like stage 3B and stage 4. We all know that stage 3B and 4 carry a limited options of treatment. Now, in oncology, in the landscape of oncology, our idea is to make a homeopathic lens. Rather, how we can make an entry point to the vast billionaire industry of oncology, how Ayush systems in general, or homeopathy in particular, can make an entry point and make a significant stamp of mark. So this study was conducted in our center, and directly I'm going to the results. So today's agenda is we have to get an understanding of a background and the challenges behind homeopathic approach, our results, and naturally our future road trajectory, how we can go into the future. The global lung cancer challenge is a current clinical reality. As of you all know that now histopathology carry a limited diagnostic benchmark. Now NGS, next gene sequencing, is the current medical discussion, because identifying mutations paves a great way of immunotherapy or targeted therapy apart from our conventional understanding of chemoradiation. Because as you all know, stage 3B and stage 4 carry a limited options of intervention by chemoradiation, as it has disseminated the disease. For example, a node may be infected from an ipsilateral side to the contralateral side also, making the disease progressive. And with all other comorbidities, it may be a great challenge to act. That's why stage 3B and stage 4 are focused and given under our treatment. Mutations, just like EGFR, epidermal growth factor receptors, alanine transferase, ALK, Kirsten KRAS mutations, these type of mutations are now being identified, and if it is positive, they can give indicated medicine like gefitinib, afatinib, or osimertinib, which are very costly and which may be very difficult to procure. The main problem is overall the cancer landscape of lung cancers, mutation studies results only below 40%. So apart from the 40%, the lion's majority of 60% is with unidentifiable mutation. So when we focus a study, it is better to do it as cases stage 3B and 4 with unidentifiable mutations. Then it will be more genuine and it will be more focused, and we will get a seat in the long landscape. Why homeopathic intervention? Why an individual choose homeopathy in such an advanced case, or rather advanced pathology? We all know that we may talk against conventional medicine and we always owe that we are in a higher position. No. we need coexistence, we need synergy, rather cohabitance. Congruence is the idea. We need congruence with all systems of medicine, because at the end, the patient has to be benefited and the professional brethren has to be improved. So if a patient asks, or a relative or a bystander asks, why I can choose this medicine at this critical time, we should have an answer. And this is the answer. It can provide the best supportive care at this time. Also, our study focused on arsenicum iodatum, a specific medicine applied on 10 cases. Arsenicum iodatum in multiple potencies. Why arsenicum iodatum is a historical thing. I am not going for the references. So this was our outcome, clinical outcome. Total 10 patients were there, all stage 3B and stage 4. PFS means progression-free survival. What is the difference between median survival rate and a progression-free survival rate? Progression-free survival rate points to the significance of an intervention, and median survival rate is without an intervention, how long the patient can go. That's median survival rate. If our treatment or our intervention can focus and make escalation to a good long lifespan, then that is the significance of progression-free survival. Apart, the period should be, the extended period should be without intervening infections. In between, we need cytoreduction, we need metastatic reduction, we need nodal reduction, and we have to prevent complications, especially lung collapse, consolidation, and then pleural effusion also. These are the common complications we encounter during lung cancer treatment. So patient demographics point to age range is 43 to 66 years. So the median can be seen. Stage 3B, 50% of the patient, and stage 4, 5 cases were taken. Add-on therapy. As I told you earlier, we can't boast to a medical community saying that homeopathy can handle an oncology, especially an advanced lung cancer. It won't be a good thing to listen or to broadcast. So the better thing is we have to get into the entry, we have to get into the medical landscape of oncology through a homeopathic lens. Just say that add-on or adjuvant treatment. After a definitive treatment, you can try this. Or if a patient is presenting with unidentified mutation, with multiple comorbidities, with a history of immunocompromised status, definitely you can take it as monotherapy. Otherwise, you can take it as an add-on therapy. That's why our treatment modalities, add-on therapy for 7 patients, monotherapy, that means standalone for 3 patients, post-surgical cases or post-radiation cases, there were 60% of the cases. And clinical outcome, always as homeopaths, we should tell in simple language that what benefit homeopathy can give after an intervention. You forget about oncology. You can, in any case, the clinical outcome will be modified better. That is the simple answer. What benefit I can get? Your clinical outcome can be modified. And that explains a progression-free survival or an extended survival with good quality of life. Don't focus on quality of life, because quality of life is a logical corollary. If a patient is getting good progression-free survival, it means it is understood that he is having a good quality of life. So clinical outcome, progression-free survival, we got a range from 70 to 204 months, which is a long range. In 80% of the cases, no new metastasis was recorded, and size reduction was also achieved in patients. So this is the detailed slide, which may not be clear to the back. Just for the information, stage 4 NSCLC, non-small cell lung cancer, where EGFR mutation was positive in first case, we did it as add-on. In second case, non-small cell, again add-on, left upper lobe, lesion size are specified there. Stage 3B, this fourth case was ALK positive, and osimertinib is the medicine which is very difficult to manage for a long period of time. Stage 3B non-small, and one case was small SCLC also, small cell lung cancer, which is very fatal. because compared to NSCLC, SCLC carry a bad prognosis. So how can we plot it? Progression-free survival in months. Case 7 showed a good progression, which is miraculous, 200 months. So outstanding outcome, how can we note? Case 7 achieved 204. This is another platform we should identify how homeopathy modify clinical outcome. It stabilizes the disease. That should be the idea. Don't say that it is cured. No. First of all, our intervention in I am speaking about advanced pathology, pathological cases. In advanced pathology, you better say that now it's possible to stabilize the disease. Then do continuously our work. The patient will be definitely into the trajectory of curative pathway, rather into a more better outcome when compared to the previous. Range analysis showed 17 to 204 months. So how can we identify key treatment outcome and clinical benefit? First is disease stabilization, size reduction, as I told you, quality of life and safety profile. These are the 4 methodologies where we can say something which we did. There is a famous quoting from Alphonse Delay Martin, who recorded that when we have a limited resources, first thing. Second is when we have a heightened or sanctified aim. And the third is when we get a miraculous outcome. See, miraculous outcome, heightened aim, but with limited resources. These are the testimony of humanism or human evolution to assess or to record a success. When we analogize with homeopathy, this comes true again for master also. How can he do this? With limited resources, with a heightened and sanctified aim, and with a marvelous outcome. So detailed case highlights can be summarized like this. Our exceptional responders were 204 months, 141 months. Arsenicum iridatum in multiple potency, everyone may be curious enough. 6C, 30, 12 were frequently used. Also in LM potency, 0Y3, 06 and 012. Don't think that arsenicum iridatum was only given. No, in between, whenever they had acute infections or acute pneumonia, because these patients were treated in inpatients and also. So in between, we had multiple encounters. Those time, our medicines could save them. Many medicines were used in physiological dose, in intercurrent, thuja, medorainum, basilinum, intercurrent medicines were used, but the main anatomy was continued with arsenicum iridatum. So the objective evidence, you might have gone through that magnum opus book by Siddhartha Mukherjee on cancer. In that book, he records that one question is being asked to Siddhartha Mukherjee that how he judged complementary medicine in oncology. The answer is very straight. He is of the opinion that the metrics should be correct. You have to get an objective evidence. Don't record that patient after your treatment, I feel better. No, that won't be accepted by a scientific community. The evidence should be objective. That's why we did PET scan before and after. PET CT before and after was taken, and clinical status monitoring shall be done, and quality of life absolutely shall be done on International Oncological EQL questionnaire. So these were our add-on therapy and monotherapy where the distribution shows how can the outcome. Every time we have to go through this analysis, SWOT analysis, strength, weakness, opportunity and threat. Whenever we get a problem, use this formula. This will give you a good result. Take a paper, first record your strength. What are our strengths? What are our weakness? What are our threat? Then definitely you will get the last answer. What are our opportunities? This you can apply in institution, in your personal life, in study, everything. SWOT analysis should be done. So strength, I am not enumerating the details, it's clear. Strength are clinical imaging correlation, PET-CT before and after. So that's a clear thing. We can't go for biopsy again. That is detrimental. It may be good for academic purpose, but it is very detrimental to the patient and the bystanders. Don't try to combine academic excellence with clinical limitations. Consistency of the result across the case and comprehensive monitoring are the strength. The weakness, absolutely small sample size. We need larger group with controls. Here no control group was there. For this, we are planning now to make a historical control group with some good cancer centers where the same range of patients at the historical demographic data where they are using chemotherapy, radiation or immunotherapy or other therapies like hormone therapy or targeted therapy. What are the threats? We need validation. Whenever we speak of some medicine getting an effect in oncology, we have to translate the science in vitro. In vitro studies are being conducted now. We need molecular profiling, we need apoptotic studies, cell cycle regulation, how this medicine is being done, and these studies of arsenicum adatum is being done at two centers. One is at KUSAT, Cochin University of Science and Technology, and CCRH is funding that. I am grateful to Dr. representing CCRH. That program is going on at KUSAT. Last year, our respected DG had come over here and signed the MOU. So molecular profiling of arsenicum adatum is being done by a state-of-the-art scientific center. And personally, I am doing it for my PhD studies. So by and large, I too expect that validation, cell cycle inhibition or apoptotic modification will be the next discussion, fortunately. So definitely our opportunity is now, our homeopathic lens is clear, getting an entry into the medical landscape of oncology. So what are the clinical implications? We got an objective evidence support, quality of life and supportive care integration. Always focus on a best supportive care in an advanced pathology. Don't go for higher ends. Best supportive care that can be offered as a first line step. So this can be plotted as a timeline. It's clear. What are the key insights? An average progression fee got 68 months. This is because one case attained 204 months. That's why the PFS progressed this much. So integrative oncology, coming to integrative oncology. By this only we can say that we are also into integrative oncology. We can't integrate one fine morning. After hearing a lesson, after reading a chapter, one practitioner from one discipline thinks that, yes, from tomorrow I may be a new man. No. Addressing a single symptom, addressing a single thing while ongoing a treatment is integration. In Mumbai, there is a gynecological center, oncological center run by one Malayali, one famous doctor is there. She is having an oncological team with a homeopath, with a naturopathist, with a physiotherapist, with an oncological nurse. That is her oncology team. And during chemotherapy, just to get rid of that nausea, obstinate nausea, she uses arsenicum album regularly. That is the idea of integration. At the end, we have to deal with the suffering of a humanity. Humane approach, or rather humility, should be there. Collaborative care, we need seamless integration. Apart from beyond borders, we have to act. That's why I always urge the new generation homeopaths to stay there, don't stick on melling other science. Just say our side, then they will come and embrace. Because with synergy, with coexistence or cohabitance only we can emerge. Don't think that we are the only thing. We need, because multiple brains and multiple industry or huge amount of money is being invested in investigation and doing research. So don't try to judge this type of massive work in a single thing. Always think that, yes, together I can smile, or alone I can smile, together we can laugh. That should be the idea. So dual focus is there, survival metrics and also quality of life indicators. future potential, establishing evidence-based protocols. With this, we had created safety protocols for each and every malignancy. So it's very clear at the front office itself, when a new patient reports, just looking into the checklist of our protocol, no, this can't be taken now. Yes, get in. This can be, this cannot. So now there is no problem in continuing with the center. At the beginning, it was a problem. How can a homeopathy cancer center exist amidst this watching our enemy, maligning people? Now it's clear. They too understood that what we are doing is a great thing. What we are doing is try to complement the thing. At the end, we have to benefit the patient. Don't think that we have to be a good, great person. We have to be good, but don't think that we have to get great. So research, future roadmap, we need rigorous study design. As I told you, molecular exploration, we need integration protocols. Mechanistic studies. Mechanistic studies includes apoptotic study. Whether our result on arsenicum adatum showed significant result on apoptosis. If a thing is influencing apoptosis, definitely we can say that that can be an anti-cancerous medicine. And we did repeated studies. Whether this alcohol, extra neutral alcohol, is making the change. No, alcohol could only do necrosis. It can't do apoptosis. So results are clear, but it has to be repeated. MTT assay was repeated. Now clonogenic assay is being done. RT-PCR is on the pipeline. So results may come. Clinical trials conduct large randomized control trials with multi-center approach. We need protocols, programs, and regulatory framework also is the key thing. Coming to the last, the integration of this is what is the key study finding? We need integration. With integration, the result is? Disease stabilization. With disease stabilization, what we get? Good survival. With good survival, what we get? Good quality of life. And with good quality of life, what came again? We could say with correct address that we can also do something. And that can't be excluded. That is the change. This is our center. Thanks to Malappuram District Panchayat, Department of Homeopathy, and our Honorable MLA Shri A.P. Anil Kumar. When we envisaged a center like this, numerous obstacles were there, but now this 10-bedded hospital has progressed to a 50-bedded state-of-the-art hospital with touch of perfection, where technology blends with humanism. It's easy to be a human being. It's easy to be a Homo sapiens. We can be called as a Homo sapien, but it is very difficult to be called as a human being. We are doing a noble profession, but this noble profession carries multiple faculties. But for that, we have to understand, we have to adjust, and we have to be in synergy with the ongoing practices. Now we have state-of-the-art laboratory where we could do all tumor markers, physiotherapy, yoga, all allied sciences, independent rooms with state-of-the-art facilities for oncology patients. So all infrastructure is now. I personally welcome all to have a visit to our center, but government has not announced the 50-bedded hospital now. It's already a 10-bedded hospital, but the infrastructure has been great. Thank you. Any questions I can take?
Thank you, Dr. Vinu Krishnan. A nice presentation.